Good morning, afternoon, evening, everyone, and thank you for joining us today. I'm Patricia Debs, and I have the pleasure of sharing this session alongside with my co-chair, Dr. Sunil Anand, and we are excited to guide you through today's presentation. Before we begin, a quick reminder of a few housekeeping points. So please make sure to mute your microphones when you are not speaking to avoid background noise. Presenters, kindly turn on your camera while presenting and feel free to share your screen. So each presenter will have 8 minutes for the presentation, followed by 6 minutes for Q&A. And if you have questions, please post them in the Q&A chat box. You can also vote on questions you would like answered by clicking the thumbs up icon. Now it's my pleasure to introduce our first presenter, Dr. Mahfuza Rifat from Damien Foundation Bangladesh. Dr. Rifat will be presenting on the topic assessing the effectiveness of Intensified Extended Contact Survey to routine leprosy case detection in Bangladesh. Dr. Rifat, over to you.
Thank you, Professor Patricia. I'm gonna sharing my screen. Welcome to our presentation so today we will be presenting from a LRI supported study that has been conducted from 2020 to 2023, and the study was on mainly the Intensified Extended Contact Survey, IECS, for leprosy in Bangladesh. And today's presentation, I will focus on the temporospatial cluster analysis part that we conducted on the data from this study. You are already aware that Bangladesh is one of the 23 priority countries for leprosy, according to the WHO, with a new case detection rate of 21 per million population. And so as I already mentioned, we have conducted the research on assessing effectiveness on Intensified Extended Contact Survey for routine case detection in Bangladesh. And the study took place from March 2020 to December 2023. And that also included some periods of the COVID-19 pandemic. So this presentation will include the temporospatial cluster analysis. I already mentioned that. And also this study was implemented. It implemented the active screening, including the household and neighboring contacts, as an important approach of leprosy to halt transmission. So just the background of the previous study to start my temporospatial analysis. So what we did in the main study, actually we conducted the active screening of leprosy in the household and neighbor contacts that is not routinely done in other areas. So that was a special intervention under this study, and mainly for the new cases. And we conducted the intervention in 7 districts. So it was implemented, and the other 7 districts were used as control. So in this cluster randomized study, we ranked the districts by leprosy endemicity. And intervention arm, we recorded the GPS coordinates of new cases, and we screened the contacts within a buffer of 75 meters of each index leprosy patients. And we used the temporospatial cluster analysis using Kuldorf's temporospatial scan statistics for identification of hotspots, and that was conducted. So with the results, the overall study, we actually there was 347 and 380 index cases in intervention and controls respectively, and For the temporospatial clusters, we found 8 clusters, which included 288, like 34% of the index cases in those clusters. And the first 2 clusters I'm going to show in the next table were statistically significant and with 183 new cases in total of 2.6 million population between so we did the temporospatial cluster analysis mainly between 2022 and 2023 because due to the COVID there was a mass disruption of the implementation, and some of our numbers may not give the similar picture which is before and after the COVID period. So we took for this temporospatial analysis, we especially considered this period. And the first cluster showed 5.6-fold higher relative risk of leprosy transmission in those subdistricts included compared to the subdistrict not included in the cluster. And also we found 2 other clusters with nearly 6.3 and 8.3-fold increases in relative risk respectively. So this is the table showing the periods and the population of each clusters and the number of cases and relative risk. We found only 3 clusters as significant under this analysis. And for the mapping of the specific clusters, we can see the colors in it. So we mainly, for Damien Foundation supported area, the 14 districts we work, and also in this study we included 14 districts out of the 64, and then we made the clusters from this map. And so in brief, actually we, for a conclusion, with what we found that we can target spatial clusters for any future intervention to cut transmission. And that can be targeted for active case detection, post-exposure prophylaxis to maximize the effect. Spatial targeted area would help us to minimize the cost. And we need to assess the clustering at the lower administrative area to be cost efficient. So beyond district, we went to the sub-district level. And a methodology that we used for the broader study to outline the hamlets, like 75 meters from the index patients, and reaching out the neighbors and also the family members, household contacts, and also the assess the clustering at this level could be applied rather than using the general as a whole, targeting all people in the community. So we are very grateful to LRI to support our study, and also we our collaborators were the Institute of Tropical Medicine, Erasmus University Medical Care Center Rotterdam, and also my all colleagues. I'm very I'm thankful to them who supported and were engaged in this research. Thank you.
Thank you, Dr. Rifat, for the insightful presentation. We will now move on to the Q&A session. So I'll hand it over to my co-chair, Dr. Sunil Anand, who will present the questions submitted by the online audience. Any questions?
Thank you, Patricia. Thank you, Dr. Rifat. There's one question from Paul Fine. What is a cluster?
So we tried to make like in a very easy way. If I can explain it, this is the clusters we tried to make based on the geographical presence and the number of patients, like a kind of hotspot. So that is how we develop the clusters and the sub-districts with a higher number of patients and lower number of patients.
Thank you. And there's another question from Wim Brakel. Says, thank you for your presentation. You mentioned relative risks, but it was not clear which categories you had compared.
In this study, actually, we mainly try to look at the numbers, like the higher the sub-districts with high number of high burden, high prevalent incidence of leprosy, and sub-districts with low incidence. So that's how we categorize, and then so that's the main thing. So those sub-districts who has the higher number of index patients detected during the time.
Thank you.
Thank you once again, Dr. Rifat, and the use of GPS and the special analysis for active screening is a fantastic approach to improving leprosy detection and halt in transmission. Thank you very much for your presentation, but we still have 1 or 2 minutes. No more questions, Dr. Anand?
No questions as of now.
We still have 10 minutes in the end, so if anybody wants to make questions or comments, can go to the Q&A icon, chat box, and pose your question there, please. So okay, let's move on to the second presentation, setting an external quality assessment program for enhancing capacity building, focusing on the microbiological tools used in the diagnosis of leprosy and the detection of drug resistance. This presentation will be given by Professor Emmanuelle Cambau. Just a quick reminder that we have this Q&A chat box, and please use this to pose your question. Professor Cambau, the floor is yours.
Morning, good afternoon, good evening, it depends where you are. Do you see my slides? Yes. So first, many thanks to LRI for organizing this virtual meeting, so I can present you the improvement of my research program, which is setting an external quality assessment program for enhancing capacity building, focusing on the microbiological tools used in the diagnosis of leprosy and the detection of resistance. So that's a very long title, just to say AQA in leprosy microbiology, because we're not used to this accreditation or certification process in the leprosy field. And I'm conducting this research with my colleague Alexandra Aubry. We are both working in the National Reference Center for Mycobacteria in France, also working at Paris Hospital. And our research was also done in collaboration with Fondation Follow for many, many years. So the rationale for this project, we work on antimicrobial resistance for many, many years in our department. And as you know, AMR does exist in leprosy as it exists for all other bacteria in the world. And unfortunately, the microbiological diagnosis of leprosy was nearly abandoned in the 90s because we thought that leprosy will end very soon. And in many places, there are no laboratory to help the clinician to diagnose and also monitor the treatment, especially with antibiotics. And because, as you know, Mycobacterium leprae is not growing in vitro, molecular detection of resistance was set thanks to Stewart Gold team who start with rifampicin, and now it's recommended for AMR diagnosis since 2009. And then WHO strategy include the AMR diagnosis in its strategy, and now it's mandatory for some of the cases, let's say 10% of new cases and all relapse cases. But still, if you look at WHO report of AMR, annual report, there are no data. In 2022, only 11 countries declare AMR results. Does not mean they declare they have a resistant case, but they have tested for AMR. And 2023, only 12 countries declare. And that's less than 1% of the cases all over. And that's the question is, why AMR is not reported? We know many labs in the world are able to do that, but they are, we don't know, organizational technical difficulties that they are not, these results are not reported, or maybe it's not done routinely. But we may also wonder, like all the laboratory results, are the report results valid? Because you may have heard whether it's resistant to rifampin or not. We need to be sure. And we need to know who is involved. Is it the Ministry of Health, program managers, doctors, patients, etc.? Sometimes it's only research, it's not diagnosis. So our objective was to develop, provide, and evaluate for the first time an EQA program for leprosy labs in order to validate the quality of their results and the management of the results. And so at the end, let's say, we'll have a network of laboratories certified or accredited that could help in the diagnosis and monitoring of treatment of leprosy. So our research has several steps. So the first one was to prepare the EQA specimens. Of course, we were not thinking about sharing human specimens we receive for diagnosis. So we built a collection of mouse food pad preparation with different strains, susceptible and resistant to antibiotics. And then we accreditate the process while we prepare them. And also we need to be sure that if we send the samples to the lab, they will be able to have a good result. So we need to test them before sending. And so we had a pilot testing with 5 labs. And the results were quite good, although we realized that it was not easy to share samples with mLepre. And also the results, although we had very good labs, they were not 100% perfect. So in the second step of the research, we now choose the list of leprosy labs we'll work with. So we set a questionnaire that was sent to all the people we know, and also to program manager, WHO, ILEP members. And so we have now a list of labs, you will see about 40 with testing capacity, and we'll send them the samples. And they will also send us some sample to check. And then we'll synthesize results. We use Visio meeting for networking. It's more easy sharing results. And I hope at the end, we'll have certification, or at least enhancement of quality and sharing protocols. So let me show you the result we have this year about the questionnaire. So we received answers from 38 centers from 28 countries. Of course, in India and Brazil, we have several centers, 9 priority countries. These centers, they are country or region reference lab. 70% report to program national leprosy. You may see it's high, but also we miss 30% of the results. Only 30% are certified, accredited. So that's one of the reasons we are doing this work. So they still do microscopy for 80% of them. And many, you see 85% are doing PCR for mLepre detection, and even 40% for lepromatosis, and most of them is real-time PCR, and most of them are doing AMR detection with several different tools. we can have a look at the end. They have about 150 samples per year, but of course, if you see on the right, there are, of course, labs where they have many, many more samples, and you see on the world map that we have, I mean, labs quite all over Africa, EMRO, and the Western Pacific, and of course, zero. Quality management, 80% they are in the way to get accreditation.
Professor
You hear
Cambau,
me?
just
Yeah?
a gentle reminder that we've gone past the time slot. Please conclude in the
Okay,
next
so
minute.
they all have SOPs, SOPs, and they want to participate. So as I showed you, in green, we did that already. So very thanks to LRI Scientific Committee, we got 6 more months to end because we had problem with staff. And now we'll send the downstream AQA and get the samples back. And by the end of the year, we have the synthesis of results and deliver capacity certificates. So the positive issue and challenges, I think I already talk about that, and so that the reference, and so thank you very much for your attention. I'm sorry to be so long.
Everything is so important. Thank you very much, Dr. Sunil.
Thank you, Patricia. Thank you, Professor Cambau, for the presentation. As of now, there are no questions for Professor Cambau, but there are 2 questions for Dr. Rifat, which probably we'll take at the end of the presentations, unless there are no questions at this time. How do you want to do, Patricia?
Yeah, can pause in the end, because for this, no question.
There are no questions.
This project is crucial step in improving the quality and consistency of microbiological diagnostic practice for leprosy. And it's very, very important, especially in the context of detecting drug resistance, of course.
We have
no question for the others?
We have 2 questions now.
Okay, great.
From Becky, says, what % of new cases submit samples for AMR testing?
Yeah, in the 2016 strategy, but that's also 2020-2030 strategy. And in the guide for AMR surveillance, it is written that about 10% of new cases should be studied for AMR testing, which in some countries, of course, that's a lot. In others, it's not. For instance, in my country, where I receive about 200 samples per year for about last year 70 cases of leprosy. I mean, we test all of them. But of course, if they are low positive, it's very difficult to have AMR results. So usually you have AMR results when it's more than, let's say, 2 plus is a good, over 2 plus. And of course, if the patient, if it's retreated cases, very often you do not obtain results because there are not enough bacilli in the sample.
There is a question from Michaela. Have you heard feedback from the labs regarding their experiences with the new standard SOPs?
I'm sorry, maybe I don't understand really your question. I mean, you know, each lab, they have their standard SOP. I mean, they have their SOP. And if you, in the questionnaire, we see that more or less we all work the same. Zil-Nielsen staining for microscopy, real-time PCR following the protocol of Truman, and then AMR detection. Then it could be a little bit different. We have on my slides, maybe you will see, if you get the slides, there are the different tools. Of course, you can change the tools, but I don't really understand what you mean by new standard SOP.
Question from Sunil Modali. How many countries have funding for conducting AMR surveillance as part of routine activity?
That's a good question. Of course, founding labs is important, but if you remember 2020, when we had this COVID pandemic, I mean, the labs were found. I mean, they got money to do the PCR in many countries, and in many countries where leprosy is a real problem, and where there is no money for leprosy labs. So, I mean, we need to consider that there are different infectious diseases, but leprosy needs also some funding and diagnosis. So.
Yeah. Another question from Zalalim. Thank Professor, but consider the issue representative selected sample. Since most labs are in endemic countries using microscopy, how many labs participated from Africa?
Yeah, thank you for your question. You know, in Africa, there is development of network of laboratory for diagnosis on NTD, neglected tropical disease, including Burley ulcer. And they all use PCR for that. So the idea is to just add another one like leprosy. And so it cannot be all labs, but reference lab can do that. Thank you. And there are many labs in Africa able to do that.
Thank you. This is a question from Dr. Pai. Did you find drug resistance to M. lepromatosis in the samples screened? And if so, which lab and in what number?
To my knowledge, I mean, in my lab, we don't have lepromatosis cases, but in other lab, I think it has been said that some dapsone resistance could be, but I don't know, because we don't know the data. That's the objective of the project, you know. But I hope to be able to answer you in the future.
Yeah.
I think we need to move on.
Yeah, there are two more questions which we can push to the end of the presentation.
Yes.
Yeah.
Yes, definitely. Thank you. Thank you, Professor Cambau and Dr. Anand. So, but because we have a time to be quite strict on it, so let's move on to the third presentation. The title is Capacity Building for Leprosy. This presentation will be delivered by Dr. Tsaku. And just a quick reminder, each presenter has 8 minutes for the presentation, followed by 6 minutes for the Q&A, and we have 10 minutes in the end. Okay, Dr. Paul, please proceed with your presentation.
All right. Thank you very much. Hello, everyone. My name is Prof. Tsaku, and I work for the Leprosy Mission Nigeria. So I am a co-investigator in the Capable research. Capable stands for Capacity Building in Leprosy. In the research team, we have the lead investigator, Dr. Sunday, and co-investigators, Dr. Joydeepa, Christine, Lisbeth, Srileka, Praveen, Mikhail, and myself. Introduction. So the limited or the dwindling capacity of frontline health workers has led to delay in inadequate care, and that has dominated discussions in the global health community of late. The WHO roadmap highlighted the need for integrated capacity strengthening to eliminate NTDs. The capable research evaluates the impact of blended training that is based on the InfoNTD e-learning platform, and it's being piloted in India and Nigeria. The main research question is on the impact of using blended approach on the acquisition and retention of leprosy knowledge, skills, and performance of healthcare workers who are working at different levels in India and Nigeria. The follow-up questions are, one, what are the resulting improvement in knowledge, skills, and performance in suspecting and referral, diagnosing and treatment and management of leprosy complications? The second question is on what is the acceptability and usefulness of a blended learning approach for leprosy capacity building in the perspective of the trainers, supervisors, and the trainees. And the third question is on what is the contribution, or what contribution do formal and informal learning make to knowledge and skills retention? And the final question is on the costing of the training interventions. The research design is a longitudinal intervention study, and it's based on the Kirkpatrick model. The Kirkpatrick model has 4 levels of training evaluation. The first level is on the reaction. That's where we evaluate the participants' satisfaction to the training approach. And the level 2 is on the learning. And this evaluation is based on pre and post test of the participants. The level 3 is the behavior, and that we observe at the 3-month follow-up. And then the level 4 is on the result. What impact does the training makes overall on the participant, and that is at 6-month follow-up. So I mentioned earlier that the capable research is taking place in India and Nigeria, and we plan to enroll 180 participants into the study. That is 90 participants in India and 90 in Nigeria. And our participants are categorized into 3 levels. The first level are the frontline health workers, who are also the community volunteers. And level 2 are the primary health care or the referral hospital clinicians. The level 3 are the supervisors at the ministries of health. So up to this moment, the project started in July 2024, and it's running through to May 2026. So at this very moment, we've recruited 93 participants in Nigeria and 45 participants in India. Recruitment in India was delayed by some factors, such as obtaining ethical clearance for the study and also obtaining the necessary approval. But we are on course, and we are confident that we will achieve our target in India. The training course is developed for this study, stigma and mental well-being course, the general leprosy course, and reaction course. So up to this very moment, I mentioned that we recruited up to 93 participants in Nigeria. So we had a preliminary assessment of our findings so far. And on the left side of my screen is a chart where we try to analyze the pre and post test scores of our participants. And this is of 42 participants in Nigeria. And in the chart, you can see that out of the 42 participants, we have 10 participants whose score did not change at the pre and post test. We also have 8 participants with 10% improvement in score and 4 participants with 20% improvement in score. We also have 5 participants with 30% improvement in score and 6 participants with 40% improvement in score, 3 participants with 50% improvement in their score, and we also have 1 participant with up to 70% improvement in score. There are also 3 participants whose score were invalidated, possibly because one of either the pre or the post-test result was missing. Interestingly, we also, in this case, we have 2 participants with a negative score. That is, 1 participant had less 10% decrease in performance, another with up to 40% negative score in the post-test. So these are some of the parameters that we will be analyzing at the end of the study. We will try to explain why this occurrence, the possibility that participants are having negative score, and we will also analyze to see if there is any significance in the number of participants with such kind of result. Also, with regards to participants' satisfaction with the blended learning approach. So I needed to mention that the blended learning approach means that the participants are exposed to learning modules online as well as physical learning, and they are also encouraged to have some learning to try to learn on their own while they are working, and that is a form of informal learning. So here is a quote from a participant who expressed their satisfaction, and they say here that they enjoy the blended learning format because it gives the opportunity to learn on your own and at your own pace, and that you also have the face-to-face meeting to further enhance your learning, as well as having practical session. So,
okay, right.
All right, so acknowledgement. We would like to acknowledge the St. Francis Guild for co-funding this research together with LRI. We also acknowledge the contribution of the Leprosy Mission Great Britain, particularly funding the face-to-face training. And also we acknowledge our research advisory committee and the Leprosy Learning Steering Committee, the Federal Ministry of Health in India and Nigeria. We also appreciate our participants and the learning platform, InfoNTD e-learning and Health e-Foundation. And thanks to our research assistants as well. Thank you very much for listening.
Thank you, Dr. Paul Tsaku, for your insightful presentation. Very, very good. Before to go to Dr. Anand, just a quick reminder that you can also vote on questions you'd like answered by clicking the thumbs up icon in the chat box, the Q&A chat box. Okay, Dr. Anand.
Thank you, Patricia, and thank you, Dr. Paul. There's one question from Ngozi. What could be the explanation for negative scores after the training? Guesswork for pre-test or confusion after post-test? Kindly give some explanations or clues.
Okay, the question is on what could be the reason for, what could be the explanation for a negative score. So at this point, we cannot say exactly because we will do a final analysis at the end of our research. So the analysis is still ongoing at the moment, but we can actually assume that the participants probably misunderstand some concepts, and which we also try to address. at the end of our at the end of our assessment. We also imagine the possibility that we imagine the possibility that the participants must have seen something else. It's too early to actually make a conclusion on that. I think Dr. Ngozi, the follow-up question is also give some explanation or clue. Yes, so the pre-test was done online. The pre-test was done online by the participants. So, and then the post-test was done immediately after the training was delivered. So, and the differences in personality can also lead to this. So we are still open to all the possibilities. And at the end of the day, we can say definitively what could be the reason.
There is one question from Bahadir. Just for clarification, the pre-test was online, but the post-test was wanted to know whether the post-test was in person.
Yes.
I don't think there are any other questions to Paul. Should we then take the other questions for the previous presenters?
Yes, we are on time, so we just move to the additional 10 minutes for discussions. Yes, please.
The questions to Dr. Rifat, Michaela says, was 75% radius for contact screening validated in this population?
Not in this population, but there were studies who used the hamlets mostly about 100 meters. So we use 75 meter in this study, and also we found that it's not always like exactly 75 meters. You know, we use the GPS coordinates to identify that, but based on the the geographical location and the clustering and grouping of the community, we also increase and decrease the hamlets. So there, that was also in the methodology of our study. So, so we chose 75, considering the very high density of population in Bangladesh. And but we found references of with 100 meter mostly.
There is another follow-up question from Paul Fine. Yeah, it's still not clear what a cluster is. What is your definition in terms of space and time?
So for the in terms of time, I would say it's more on the space focused here, and we considered that the mostly because the time, as I mentioned, we took 2 years of times after COVID period, but we for the analysis actually. What was done, the space is like that. So initially we tried to, it's the cluster is actually the similar type of types of characteristics that presenting from the similar geographical area. So that's how we define the cluster. So it's based on the patient number and also as well as like the characteristics of the population number and the population of that geographical area. And also we considered that because mostly the interventions were similar in across the Damien Foundation supported areas. So these are the things we consider during the cluster identification. Yeah, but we are now having developing a full paper, so maybe we can respond to the more questions like yeah. So if it's not yet clear.
Thank you. Dr. Rifat. I think those are the questions for you. Now, there are a couple of questions for Professor Cambau from Kidis Babosha. Thank you, Professor. As a reference lab, do you give technical support to labs that would like to establish the AMR molecular assays?
Thank you. We started the surveillance network in 2008, and there were several labs and several NGOs participating. I mean, most of them are participating to LRI. So personally, I work with Fondation Follow, and so, of course, we're helping technical support for the countries working with Fondation Follow. That means Africa mainly, but many different countries like Benin, Mali, Niger, Madagascar, and several others. But of course, in other places, I know the reference center in Japan, they worked a lot with Myanmar, with more Asian country, and there are several others. So yes, there is technical support, but all over, I think PCR is done for many things today. It's not a mystery today. So that's the reason why many labs are able to do that.
Thank you. There's a question from Nora Castro. Do you have any information about M. lepromatosis, AMR, I think?
Yeah, that's what we already answered to. I think, Nora, if there is a resistance, you will find it. Because I don't have any lepromatosis cases. I've never seen one in the country I work with. It seems to me it has been said somewhere, but yeah, I don't know. And that's a good point that we need to know. Thank you.
Question from Zelalem to Professor Cambau. Any work on capacity building lab in Ethiopia?
Yes, in Ethiopia, there is this the lab at the Alert site, and I hope they will participate to the AQA study.
Yeah, there's one last question to Paul. What significant feedback did you get regarding the blended learning approach you received?
Yeah, so the feedback is largely that the participants are very much satisfied. And that is also evident in the quote, one of the quote that I showed. So we have done follow-up, we've done interviews with the participants to also understand their perspective and what they think can be done better. And largely, it is satisfactory from the participants' point of view. Okay.
I think there are no more questions as far as I can see. Thank you.
Ladies and gentlemen, thank you all for attending and actively participating this session, A1 on operational research. I would like to extend my thanks to my co-chair for the excellent collaboration support through this session. And of course, thanks as well to Leprosy Research Initiative for organizing this outstanding meeting and creating a space for knowledge sharing, collaboration, and innovation. And let's see. Well, we look forward to continue this important meeting. Thank you again and enjoy the rest of the meeting.